Hello, everyone, and welcome to this special global webinar event, Integrating Maternal Nutrition into Antenatal Care Platforms, results from Alive and Thrive's implementation research in Burkina Faso, Ethiopia, and India. My name is Joe Lamport, and I'm the Communications Director at Alive and Thrive. The event is being recorded, and we will post it on our website and on our YouTube page. The presentation slide deck will also be available, along with other resources related to today's topic. Simultaneous translation is available for French speakers. Please click on the link in the Q&A window to access the live feed. Let's briefly run through today's agenda. We'll start with an introduction to Alive and Thrive and today's speakers. We'll then have a commentary on the importance of maternal nutrition implementation research and developing and implementing programs to improve maternal nutrition. Then, background on the maternal nutrition interventions implemented as part of the research will be presented, after which our partners at IFPRI will share key results from the research. We'll then have a moderated panel discussion on adapting and scaling interventions in the 3 countries we're focusing on today, Burkina Faso, Ethiopia, and India. Finally, we'll have time for your questions. You'll notice the question and answer window on the interface of the webinar. Please post your questions there. We'll get to as many as we can during the Q&A session. Thanks again for joining us today. I'm pleased to introduce the director of Alive and Thrive, Sandra Remancus, who has worked in this space for more than 2 decades. Sandy, over to you.
Thanks so much, Joe. Good morning, good afternoon, and good evening to everyone. As Joe just said, I'm Sandra Remancus, the director of the Alive and Thrive initiative. I think many of the participants in this webinar know that Alive and Thrive has been around for over a decade. The initiative started in 2008 with funding from the Bill and Melinda Gates Foundation for proof of concept research that's in Bangladesh, Ethiopia, and Vietnam that showed that improvements in infant and young child feeding could be achieved at scale. Since then, Alive and Thrive has expanded to new technical areas, including maternal nutrition, adolescent nutrition, and nutrition-sensitive agriculture. And we're now working across a number of systems, including the food, health, education, and social protection systems. Throughout all of this, Alive and Thrive has continued to add to the maternal, infant, young child, and adolescent nutrition research and implementation learning evidence base, and to add valuable insights about programming related to policy advocacy, social behavior change, strategic use of data, and system strengthening. Alive and Thrive is now in over 18 countries. We have regional offices in Southeast Asia and in West Africa, and we now have a number of donors and a number of new partners. The commitment to building the nutrition evidence base is still at our core. And for that reason, we are very happy today to be presenting our recently conducted maternal nutrition implementation research from Burkina Faso, Ethiopia, and India. For this research, Alive and Thrive was responsible for the implementation of a package of maternal nutrition interventions, while our partner, the International Food Policy Research Institute, IFPRI, was responsible for the research. In this webinar, you will hear about the rationale for the choice of interventions, the research results, and also about adaptation and scale up of maternal nutrition in these countries from a number of presenters from the Foundation, Alive and Thrive, and from IFPRI. And these presenters include Alison Tumilowicz, Senior Program Officer from the Maternal, Newborn, and Child Health Team at the Bill and Melinda Gates Foundation. Tina Sangvi, the Alive and Thrive Senior Mycin Technical Advisor. Maurice Gerald Zapimanyaka, the Alive and Thrive Burkina Faso Country Director. Dr. Abdulaziz Ali Umar, the Alive and Thrive Ethiopia Country Director. Sabanti Ghosh, the Alive and Thrive Senior Technical Advisor in Nutrition for India. Fong Hong Nguyen, Senior Research Fellow from IFPRI, and Sunny Kim, Research Fellow from IFPRI. So now I'm going to turn it over to Alison to talk about the importance of women's nutrition from the viewpoint of the Bill and Melinda Gates Foundation. Alison, over to you.
Thanks, Sandy. Good nutritional status prior to and during pregnancy is critical for maternal, newborn, and child health and development. But as the statistics show on this slide, the burden of women's undernutrition is enormous. More than 1/3 of women are anemic, even before entering pregnancy, when iron requirements greatly increase, putting women at higher risk of postpartum hemorrhage and maternal mortality. Being short stature, which affects 7% of women globally, is estimated to be the cause of 6 million babies annually being born small for gestational age. And the high burden of low birth weight, an estimated 20.5 million babies every year, is biologically linked to the high burden of global maternal undernutrition. Babies born small at birth have an increased risk of mortality, morbidity, and suboptimal growth and cognitive development throughout childhood. New evidence laid out by Cesar Victor and colleagues in the Lancet 2021 shows that without attention to maternal nutrition, child nutrition outcomes will continue to lag with long-term consequences. We have evidence-based interventions which could improve maternal nutrition. Maybe the next slide, please. These are laid out in the 2021 article, the Lancet 2021 article, and recommended in the WHO antenatal care guidelines. However, we have huge implementation gaps. For example, the longest standing recommendation of providing antenatal iron and folic acid supplements could reduce the risk of developing anemia during pregnancy by an estimated 47%. However, the coverage rate of women taking 90 or more IFA tablets during pregnancy worldwide is very low, ranging from about 5 to 50%. Antenatal care platforms are increasingly accessible. In Ethiopia, from 2011 to 2019, the percentage of women attending 4 or more ANC visits increased from 19% to 43%. There's a huge opportunity to use ANC services to deliver maternal nutrition interventions, but we're at the beginning of learning how best to do so. The Alive and Thrive research presented here is groundbreaking. It is one of the first to test strategies which create the conditions necessary for effective delivery and sustained utilization of maternal nutrition interventions. I'll now turn it over to Tina Sangvi and colleagues to share more about that research and important lesson learned.
We started our work on maternal nutrition in Bangladesh in 2014 after the completion of our infant and young child feeding scaling up programs. At that time, there was primarily an iron folic acid supplementation, and in some countries, they were beginning to add calcium supplements to the antenatal care routine services. But there wasn't a specific defined package of maternal nutrition interventions addressing more than the anemia issue. And we knew with the review of evidence that we needed to address a broader set of maternal nutrition problems that have significant impacts, not only on women and mothers, but also on newborns, infants, and young children. So with funding from the Global Affairs Canada, we began to develop a prototype in Bangladesh in 2014, and that led us to the finding that it is feasible to expand the package of maternal nutrition interventions to include others, But in the Bangladesh setting that we were working in, it was fairly unique and favorable. So, we were happy with the positive results, but we wanted to try it out in some other large-scale, challenging environments. India was the first one who started, and the other countries became very interested after the publication of the WHO antenatal care guidelines in 2016. This had two major benefits for us. Number one, for the first time, the antenatal care community recognized the importance of nutrition. Not only that, they specified based on evidence what the state of the knowledge was about interventions. And they promoted the idea of frequent antenatal care contacts and also a greater role for community components. So with the evidence from Bangladesh, with the tools, processes, templates already prepared in Bangladesh, our country teams found a much favorable environment to proceed with integrating maternal nutrition into national antenatal care services. The countries were also at the same time being asked to expand antenatal care by increasing the number of contacts and a number of other principles that are in the WHO 2016 guidelines. After India was able to complete their implementation research, which fortunately happened before restrictions due to COVID set in, Ethiopia and Burkina Faso were also interested. However, in Ethiopia and Burkina Faso, we faced some interruptions that were quite serious and extended in the case of Ethiopia, not only in service delivery reductions, but also concerns of the community in wanting to come to health facilities and interacting with lots of people during the COVID, at its peak during the beginning of COVID. So we did face some setbacks in being able to implement the interventions before the end line. In Burkina Faso, we also faced problems and reductions in the interactions and the exposure to the interventions. But Burkina Faso recovered very quickly. And before the end line, their services were functioning pretty well. But both these countries did suffer from being in the middle of this work with the COVID restrictions. So now, what was it that was in the package that we implemented? And how were we going to study what it takes to implement that? So here's the package that we found was ready for large-scale implementation. All the countries already had these four in their policy guidelines. But the protocols and the details of implementation, the capacities and health systems, the links with communities, the engagement with family members that are all necessary for effective implementation and uptake of maternal nutrition were not in place. So based on a checklist where we reviewed materials already in place in each country, we found several gaps, and we decided to focus on the very first one, counseling on dietary diversity and quantity, on building the capacity of antenatal care providers on how do you tailor counseling on food consumption and food choices of pregnant women. And also very importantly, engagement of family members, because in our countries, the intra-household allocation of food resources in favor of women and pregnant women depended on the involvement of other household members and also on social norms. For iron, folic acid, and calcium supplementation, two of our countries, both Burkina Faso and Ethiopia, governments had not yet agreed to add calcium supplements to the routine package of antenatal care. And so the emphasis across all three was on IFA. and in India also included calcium supplementation. Here, the two areas of focus were supplies and counseling on adherence. We wanted to increase the number of tablets consumed. And again, the family's involvement, because a lot of the iron folic acid, the daily dose, it's taken within the household. It's not administered by health workers. So it was really important, again, to engage family members. Weight gain monitoring and counseling, we felt, was really important. Number one, weight monitoring, weighing pregnant women is a standard practice and across many countries. However, that opportunity is not fully utilized for promoting key maternal nutrition practices. So that was our focus. We also recognize the growing evidence on overweight linked to weight gain during pregnancy and the importance of spreading awareness about the upper bound of weight gain during pregnancy, as much as we wanted to also make sure that women were aware, families were aware, health workers were aware of preventing underweight. So the lower bound, equally important and more important in some situations, but also the upper bound. Counseling on breastfeeding. This was considered very important because around the time of the issuance of antenatal care guidelines, or WHO, there was also much more evidence on early initiation of breastfeeding. And as we know, the early initiation needs to happen in the first 1 hour after delivery. So unless we prepare mothers and family members to be ready and capacitated and committed and motivated to place the baby at the mother's breast within the first hour, it needs to happen during pregnancy, it needs to happen through antenatal care services, because it has serious implications. Early initiation has independent effects on mortality. It also has additional benefits through extending the exclusive breastfeeding. So this was considered, and it has maternal, as you know, breastfeeding has maternal health benefits as well. So this was added as a fourth component, and this was a package that we find in all countries. Each country was at liberty to modify this package to add additional messages, and they did. Things like workload, physical activity, sometimes hand washing, sometimes promoting institutional deliveries, malaria prophylaxis, deworming, etc. But these four remained the focus of our wanting to understand what it takes. How do we ensure, how do we build a stronger maternal nutrition package within antenatal care? In the next slide, we can see how this package of four was actually delivered. So across the top, there were very similar areas of system strengthening. And we utilized the WHO 6 building blocks framework to make sure that we had looked into various aspects of the health systems to see that there were no gaps and what the opportunities were for strengthening. And they were very similar across the countries. So one of the concerns was that if, and we did, have to do system strengthening at the district level or above, it was going to trickle over and spill over into our control areas for evaluation. So this posed a big challenge, and perhaps this is not unusual that the control areas also become exposed or get exposure to interventions. And we would love to hear from our participants if there are ways that they have handled this. You'll hear more about that during the presentation of our evaluation results. Health facilities played an important role, particularly in Burkina Faso and Ethiopia, because antenatal care services and iron folic acid distribution, for example, is handled only through facilities. Now, it was workable still, because in Burkina Faso, there is a natural tendency for women to attend antenatal care. It has really higher than expected levels of antenatal care attendance. And in Ethiopia, health posts, which are placed much closer to communities, was the main venue for delivering antenatal care services, including distribution of micronutrients. So we were able to strengthen both facilities and then at the community level. So some of the countries, even Bangladesh before India, and India, of course, the emphasis was on strengthening antenatal services occurring at the community level. And as you know, there are many different kinds of community platforms that different countries have for delivering various components of antenatal care, whether it's diagnostics and screening, or whether it's distribution of micronutrients, or tetanus toxoid administration, or many other things, and counseling. So task reallocation to community health workers was an important element of our nutrition package in all of the countries. And all of the countries had different levels and cadres of community health workers, volunteers, and in the case of India, they sought out the Integrated Child Development Services, or ICDS program, to also participate in strengthening antenatal care. And counseling during home visits was conducted by workers from both the health department of Uttar Pradesh, where the implementation research was done, and also the ICDS workers, the Anganwadi workers, and auxiliary nurse midwives. In the case of Burkina Faso, it was the Agent de Santé à Base Communautaire, which is the community health agents, who were not as active, as proactive, and focused on the full package as we would have liked. So there was quite a bit of capacity building and linking them to facility-based providers of antenatal care. That was a focus to make sure that the community and family engagement was balanced in the Burkina Faso package, in addition to a lot of system strengthening. In the case of Ethiopia, the health posts are staffed by health extension workers. So the extreme right column under Ethiopia, the last row, you see HEWs, or health extension workers. And they were providing counseling during home visits to pregnant women, referrals for antenatal care, and several others. So you see a very consistent and common set of interventions and activities at the health system level, and sometimes at the health facility level. And as you get closer to community and household level approaches to strengthen nutrition in antenatal care, there's great variability across the country. So adjusting the packages, the training tools, the monitoring, the supervision, etc., begin to vary quite a bit. And we'll hear a lot more about this. For the community and individual behavior change, we looked at the socio-ecological model of behavior change, and at the individual level, a number of other theoretical frameworks to not only provide knowledge, but also self-efficacy, belief in the benefits, perception of social norms, family support, etc., to strengthen the ability and motivation and intention of pregnant women in adopting these practices. And two processes which don't pop out here, but I just want to mention: co-designing was central to the development of these packages with multiple stakeholders involved, and also adaptive management, which is basically another name for doing frequent and very focused assessments during implementation to find problems that can be addressed quickly before too late. So adaptive management, co-design were two processes that were very important during these. In the next slide, we try to summarize what we have learned. So here you can see on the extreme right the results. And our colleagues from IFPRI will go over that. But if we desire to build adapted nutrition models for antenatal care, and if we want to strengthen services for delivering high quality, high coverage of maternal nutrition through antenatal care services, and if we are not satisfied simply with delivering the services, but we also want those practices and recommendations to be taken up and practiced day to day, those behaviors to change, then what most countries will find, we believe, based on our 4 countries, is the barriers on the extreme left column are likely to be the barriers that we will find in any new setting. Now, these vary in how important they were, and they certainly varied in terms of the types of strategies that were relevant, appropriate, aligned with ongoing antenatal care, because we are part of the antenatal care package, so we must be aligned with them. And these are the strategies. The top 2 rows under strategies are providing specific protocols and guidelines, specifying what is it that nutrition really means. It's not just giving one message. It's not just having it listed somewhere, but there are a lot of details in specifications that need to be developed and designed in each country, in each program. Then we have to build the capacity to follow those protocols, to make sure they can be executed. And so building capacity was a very major stream of work across all 4 countries. And then the lower 2 rows is community channels and social norms. So these are now ensuring that all the effort, all the emphasis that we have placed in getting our health systems and our health providers and health services to a certain point of being able to deliver the package is actually benefiting. And for that, as I explained before, it's really important to make sure that community opinion leaders, social norms, and family members and their engagement and support for pregnant women is equally important in the list of strategies that different countries will be able to adopt and produce the results. So now I'm really pleased to invite our colleagues from IFPRI, Sunny Kim and Feng Nyo, to share the results of the evaluation. Thank you.
Good morning, good afternoon, and good evening, everyone. Feng Wen and I will be presenting on the evidence from the 3 countries, India, Burkina Faso, and Ethiopia, on the feasibility of integrating maternal nutrition interventions into the existing antenatal care platforms. Next slide. To address our question on feasibility, we raised 2 sub-questions. First, to what extent were the interventions integrated into existing antenatal care service delivery systems? Second, how effective were the interventions in improving maternal nutrition and early breastfeeding practices? Next slide. We collected a lot of data across many elements along the impact pathways of the interventions in each country. But to answer the question on the extent of integration, we'll share some of the evidence of the intensified maternal nutrition interventions incorporated into the government health system just along 4 components: training and use of job aids and program materials, supportive supervision, nutrition knowledge among service providers, and service use and intervention exposure. To answer the question on effectiveness, we'll present some of the impacts of the interventions on maternal nutrition and breastfeeding practices. Next slide. Tina already presented about the nutrition interventions and the antenatal care platforms across the 3 countries, so I'll just recap here the key topics addressed through counseling during pregnancy by Alive and Thrive. In Burkina Faso and Ethiopia, messages to promote early initiation and the number of antenatal care contacts was provided. Across all 3 countries, counseling on maternal diet and IFA supplementation was specified and reinforced. In India only, calcium supplementation during pregnancy was provided and counseled on. In all 3 countries, adequate weight gain and consumption of adequate energy was promoted, with message on rest and reduced heavy workload reinforced in Ethiopia. And counseling on early initiation of breastfeeding and exclusive breastfeeding was also provided during antenatal care contacts in all the countries. Next slide. So in the 3 countries, we used a similar cluster randomized controlled evaluation design. First, in India, we identified 26 blocks in Uttar Pradesh state, which are randomized and allocated into one of 2 arms, intensified antenatal care and standard antenatal care. The comparison group, which we'll refer to as the controls, still received routine antenatal care services through the government health system. Cross-sectional surveys were conducted at baseline in 2017, then at endline in 2019, with a process evaluation study in between, and comparisons were made between the program groups over time. Next. Similarly, in Burkina Faso, we randomized 80 health center catchment areas across 2 regions, Boucle de Mohun and Opazan, into 2 program groups. And in late 2019 and in 2021, we conducted a cross-sectional surveys at baseline and endline. In 2020, as Tina mentioned, implementation was disrupted for a few months due to the COVID-19 pandemic. In Ethiopia, we also had about 30 health center catchment areas with their corresponding local health posts in SNMP and Somali regions, allocated into 2 program groups. In the case of Ethiopia, we conducted a smaller baseline survey in 2019. Then implementation was extensively affected by the COVID restrictions in 2020. So the Alive and Thrive program restarted its retraining and other activities at the end of 2020. Then in late last year, in 2021, we conducted an endline survey with the full study sample and estimated differences between groups at endline only. Next slide. Across the countries, we conducted household surveys to collect data on pregnant women and recently delivered women with children under 6 months of age. We also collected data on health facilities and service observations and among antenatal care service providers at the facility and community levels. For the results presented today, we use the data of the pregnant women and recently delivered women. And at the health system level, we use data from the nurse midwives and health extension workers in Ethiopia and community-based workers such as ASHAs and Anganwadi workers in India and community health agents called ASBCs in Burkina Faso. Next slide. So now we'll move into the results on integration of the maternal nutrition training and materials. Next slide. We observed that most service providers in Alive and Thrive areas received intensified training on maternal nutrition. In this graph and in subsequent graphs, Alive and Thrive is indicated by the filled bars and control areas is indicated by checkered bars. In India here, training from left to right, training in maternal nutrition was also high in the control areas for Anganwadi workers and ASHAs, but we still observe significantly higher exposure among ASHAs and ANMs. Then in Burkina Faso and Ethiopia, a high proportion of both types of service providers at health facilities and community-based in the Alive and Thrive areas received training in maternal nutrition. Next slide. Also, nearly all the service providers in the Alive and Thrive areas received and reported use of job aids and materials on maternal nutrition, which we measured by showing an image of the different materials with the covered text and asking about their key messages or content. So for example, here in Burkina Faso, over 90%, we show that 90% of the nurse midwives and ASBCs use the counseling tools, posters, and handouts during service provision. But as shown here, we also observed in all the 3 countries that about 40% of the service providers and control areas also had the Alive and Thrive job aids and materials, which indicated some program spillover. Next slide. In relation to supportive supervision for antenatal care service providers, next slide. We observed similar levels of supervision activities in the Alive and Thrive and control areas in India and in Ethiopia. For example, here in India, we show the exposure to supervision among the 3 service provider types. For supervision in the last 6 months, in the last 3 months, use of a checklist of antenatal care services and coaching on maternal nutrition during supervision. The proportions were similar in Alive and Thrive and control areas. Next slide. In Burkina Faso, however, we observed that supervision specifically of antenatal care services among nurse midwives and ASBCs were significantly higher in Alive and Thrive areas compared to the control. Next slide. Now Feng will present on the rest of the findings on integration and on the impact results. Over to you, Feng.
Okay, thank you, Sunny. So the third component in the integrated into ANC services, we assess the service provider knowledge. Next, please. We observe the improvement in knowledge in almost every service provider, but the level of improvement is varied by service provider in India and Ethiopia. The figure below shows that the variation in the knowledge improvement in different types of frontline worker in India. For example, for AWW, we show that the improvement mainly observed for the gain in the weight gain during pregnancy. Other knowledge also improve in both areas, but no different among the different between ANT and control areas. For ASHA, we see the improvement in knowledge is more in ANT area for the weight gain and for taking the calcium supplementation. And for NNM, the knowledge improvement observed for variety of different food and also for weight gain. So the knowledge improvement basically differ by different type of provider. Next, please. In Burkina Faso, we see that the higher improvement was observed in the frontline worker in the ANT area for almost every topic in the maternal nutrition. For example, here the figure below shows that the knowledge improvement among nurse midwife and ASBC, that among them in the ANT area, we see much higher improvement for the diversity of food with 5 food groups, the eat additional food during the meal, or gain weight gain during pregnancy, taking IFPRI or calcium supplementation. The attendance of A4 ANC visit or the breastfeeding knowledge is already very high among frontline workers. It's nearly 100% for both ANT and non-ANT areas. Next, please. So the last component here, we assess the service use and exposure to intervention among beneficiaries. Next, please. We can see that the community-based contact improved in all countries. So the figure on the left shows example of contact among the mother with different type of community in Burkina Faso. We can see that more mother in the ANT area receive the ANC in the first trimester, receive home visit, and attend community meeting compared to the control area. Similar pattern we also see in Ethiopia that more mother receive home visit, more mother attended the pregnant woman meeting or attended the community meetings. Next, please. In India, we can see that the exposure to the counseling on maternal nutrition topic improves significantly for almost every topic. Just example here, we can see that the intervention area had higher exposure to the counseling on different topics, including the eating variety of food, eating additional amount of food during pregnancy, gain weight, taking IFPRI tablet, taking calcium tablets, and breastfeeding practices. And the counseling exposure improved not only in India, it's so very similar result in Ethiopia and also in Burkina Faso. Next, please. Now moving to the next research question 2, how effective the intervention on improving maternal nutrition and early breastfeeding practices. So Sunny already presents the design, how we design the intervention and what outcome and other indicator we collected. So here we only select some key indicators that to present. So in India, we saw improvement was greater than in ANT area than in control area for few indicators. Just example, we see that the percent of women who receive IFPRI improved with the impact of 7.5 percentage point. Percent of women ever consume IFPRI also have impact with about 9.5 percentage point. However, we didn't see the impact on total number of IFPRI tablet consumed or the proportion of women consume more than 100 IFPRI tablets. In terms of breastfeeding, we see the impact on exclusive breastfeeding with the impact of 7.5 percentage point, but we did not see the impact on early initiation of breastfeeding. For dietary diversity score, we see very slightly increase between baseline and endline, but no different impact between the ANT and control area. We also conducted very in-depth analysis on the cost analysis in India, and we found that the resource constraint and also the habit of the local one is the main factor that impact the adoption of the counseling services. Next, please. In Burkina Faso, we also see no impact on dietary diversity, but we see large differential impact on IFPRI consumption. Just example here, we see that the number of IFPRI tablets is about 21 tablets more than in the ANT than control area. And the impact on consume 90 or 100 tablets of IFPRI is from 8 to 11 percentage point. We also see less impact on early initiation of breastfeeding with the impact of nearly 17 percentage point and about 8 percentage point increase in breastfeeding practices. Next, please. Ethiopia is the only country that will show the impact on dietary diversity score with the impact of nearly 0.6 food group. Or another word is the woman in ANT area is about 2 times more likely to consume at least 5 food groups compared to the control area. We also see large impact on IFPRI tablets with about 35 tablets and about 2 to 3 times more likely the woman consume 90 or 180 tablets during pregnancy. However, we did not see impact on the breastfeeding practice. It's just one important note here. We can see that like the breastfeeding practice is already high in Ethiopia. So it's a little bit difficult to show higher impact later on with the intervention. Next, please. So in conclusion, our study demonstrates the feasibility of strengthening maternal nutrition intervention through ANC service, through government health system, and it shows the evidence on different components, including the improvement on training, on use of job aids and material, on improving on supervision, improving on service provider knowledge, and on the beneficiary exposure, use of service, and improving the practices. Despite a longer improvement period, we see that the impact is still modest in India, mainly so impact on IFPRI and EBF only, And we also saw the constraint because of that didn't have impact on dietary diversity. In terms of diversity, Ethiopia is only the country that shows the impact, but not in the other countries. IFPRI impact was shown in all countries, but the level is different, with the highest in Ethiopia, the moderate in Burkina Faso, and less impact in India. And finally, the impact on breastfeeding mainly show in the most in Burkina Faso, followed by India, and did not see in Ethiopia. We also show the evidence of program spiller effect as observed in all countries. For example, the training or the use of job aid or message on counseling was spilled over from the intervention to the control, which may have led to some improvement in the control area, and it can attenuate the difference between the program group. We suggest that the sustained effort to strengthen nutrition service during ANC are really needed, and greater support to pregnant women may be required further improvement of maternal diets. Next, please. We would like to acknowledge a lot of partners, a lot of country coordinators that were involved in the evaluation of our study, improving the IFPRI office in headquarters and in 3 countries, ANT headquarters and country office, the survey firm in 3 countries, Nerman, IFPRI Sante in Burkina Faso, and the one in Ethiopia. We also appreciate the funding from for this research from Bill and Melinda Gates Foundation. Thank you for your attention.
Great. Thanks, Sunny, and thank you so much, Fong. We're going to shift gears a little bit now and hear from a panel of 11 Thrive country leaders about how the implementation research results were shared with the governments in Burkina Faso, Ethiopia, and India, and how scale up and adaptation of the maternal nutrition interventions is being supported in these countries. So I'm going to start with Maurice Gerald Zafimanyaka, our country director in Burkina Faso. Hi, Gerald.
Hi, everyone.
Great. So I have a couple questions for you. Gerald, you received the maternal nutrition implementation research results from IFPRI in August 2021. What steps did you take before and after to ensure that the government of Burkina Faso was ready to scale up the tested maternal nutrition interventions?
Okay, thanks, Sandy, for this question. But let me first mention that before the implementation research and during the revision of the policies, norms, and protocol in reproductive health in 2019, 11 Thrive supported the Ministry of Health to reinforce maternal nutrition as per the 2016 WHO recommendations in antenatal care. And a detailed and operational antenatal care directives, including maternal nutrition, were developed to accompany these policies. And then the country tested the maternal nutrition intervention integrated in antenatal care from January 20 to January 21 in 2 health regions, as it was said, in Boucles-du-Mine and the Haut-Basin. And I want to mention again that the design of these interventions were evidence-based, and there was this co-creation or co-design workshop. These are very important for to increase the ownership of the health system actors. And then when we received the implementation research results, it was available in, as we said, in August 2021. We started the process of capitalization and documentation with the Ministry of Health. So first, 11 Thrive supported the Ministry of Health to disseminate results to the governmental and non-governmental stakeholders. And during a capitalization workshop, the Ministry of Health identified lessons learned and a simplified and feasible maternal nutrition package for national scaling up. And these are based on the country context and the capacities. Also, a national training modules and job aids in maternal nutrition were validated and will be used nationwide. Another point is that maternal nutrition standards were reinforced in Burkina standards for improving the quality of maternal and newborn care in health facilities. So this is following the WHO guidance. And as requested by 6 health regions, IFPRI is providing a technical assistance to expand maternal nutrition interventions in 220 health facilities. And finally, for a phased and coordinated scaling up, the Ministry of Health will develop a national plan that will help them progressively offer the maternal nutrition package nationwide and mobilize adequate resources. Thank you. Over to you, Sandy.
Great. Thanks, Gerald. In addition to the capitalization efforts and the technical assistance that you just mentioned, I know that you also have plans for a study on the role of leadership and management related to maternal nutrition in Burkina Faso. And that's very interesting because it really takes us beyond just the technical implications of the research results to focus on the enabling environment for scale up. So can you tell us all a little bit more about that study, what it will cover, and why you see it being important? Thanks.
Yeah, indeed, Sandy, this is very interesting. Alive and Thrive planned with the Ministry of Health to conduct in July and August 2022 a study on the role of leadership and management during the maternal nutrition implementation research. As our approach was based on the health system strengthening model, during the capitalization workshop, we used the 6 building blocks to identify factors that influenced the performance of the maternal nutrition service delivery. And participants were unanimous that the building block of leadership and government is key in delivering at scale high-quality maternal nutrition services during antenatal care. But the implementation research did not collect enough data on this area. And participants recommended a follow-on study to better understand the influence of the leadership and management at each level of this health system. That is at national, at regional, at district, and even at the health facility level. And the study protocol has already received approvals from IFPRI 360 IRB and Burkina Committee of Ethics. And also the study received an authorization letter from the Ministry of Health. Thank you.
Thank you again, Gerald. And now we're going to go over to Dr. Abdulaziz Ali Umar, the 11th Tribe Country Director in Ethiopia. Hello, Dr. Abdul.
Hi, Sandy. Hi, everyone.
Great. So I have a question for you. IFPRI just showed us that in Ethiopia, there was no impact of the interventions on early initiation of breastfeeding or exclusive breastfeeding, which is disappointing. But can you tell us how these research findings were taken into account or influenced modifications to the maternal nutrition intervention package before scale up in Ethiopia?
Thank you very much, Sandy. Yes, the results were really disappointing for us as well, as we have been expecting much improvement in this area. And it was also surprising, as you know, IOSF counseling has been a key message conveyed by healthcare professionals. So once we saw these results, as you saw, most of the results are more of quantitative data. So we want to have an in-depth understanding of why there are no changes in early initiation of breastfeeding as well as exclusive breastfeeding. So to this effect, we did have like a consultative type of meetings with stakeholders, especially healthcare providers, including health extension workers. And we also did small facility visits to see what's going on and try to really review the training materials and job aids we have been using. So surprisingly, the findings we had was somewhat able to explain the low or the poor achievements of this early initiation of breastfeeding and exclusive breastfeeding. So the things we found were, one was, as maternal nutrition was somewhat a new initiative, much attention was given to maternal nutrition counseling. So we observed this finding during our field visit as well as during our conversation with healthcare providers, including health extension workers. And the other thing, especially with regard to IYCF, as it is understood to be somewhat a known type of practice, so there was somewhat less attention given to IYCF. And when we visited, when we see the training materials as well as follow-up cards or job aids we have been using, the IYCF counseling component was somewhat scanty or somewhat no much attention given. So before we scale up to the rest of the regions as well as to the control regions, we revised the training materials which we have been using for training of health extension workers and healthcare providers. And we did also some refinements to reinforce the IYCF component on the job aids we have been using. And we also revised the integrated support to supervision tools which we have been using to monitor the information. So we did these things and started scaling up. Thank you, Sandy.
Thank you. And we also just heard from Gerald about the importance of the enabling environment in Burkina Faso. And maternal nutrition scale-up is clearly dependent on governments being ready and able to expand interventions to new areas. So given that, what was done in Ethiopia to ensure government buy-in and ownership of the results and future maternal nutrition programming?
Thank you. So with regards to government buy-in and ownership, Ethiopia's 3011 Thrive project, when we started the system strengthening and capacity building project, and even from the beginning, we have been heavily engaging the government from the design phase of the implementation. For example, when we start this design, originally we had a plan to start only in agrarian regions, but when we consulted the government back in 2018, the government suggested just to have lessons from different contexts. They suggested to have an implementation both in a pastoralist context as well as agrarian context, and so we accepted that guidance from the government and intervened. So as part of ownership, we heavily engage the government from design, planning, as well as implementation of the research even before the results. So after we got the results from IFPRI, so we did a sort of result. We shared the results both at national level and regional level, and we use those opportunities to reinforce our advocacy for taking up of these interventions by the government. And when we are scaling up the interventions to other waradas and other new regions, we did the typical participatory type of engagement of the new regions, sharing the results of other regions and how to really contextualize to their context. So we contextualized the results into new regions context, the job aids, the training materials and others. Then we finally agreed with regional officials where to scale up, what part of the intervention to be scaled up, and what part of the resources to be really covered by Alive in Thrive, what part of the resources to be covered by the government. As a long-term sustainability strategy, we also try to incorporate the intervention package into like the newly revised guidelines. For example, currently the Ministry of Health is revising antenatal care guideline, as well as maternal, infant and young child nutrition guidelines. So we were able to really introduce this this package into this guideline. So we also used a different advocacy approach at national and regional level for the government to include or to allocate budget for maternal nutrition at different levels. So those are the way we followed to really make sure that the government was on the driver's seats and really buy in the interventions we have been using. Thank you.
Great. Thank you, Dr. Abdulaziz, and thank you for bringing up the issues about integration into existing guidelines, especially ANC guidelines, and also the intention that's needed to ensure that the resources are there and that maternal nutrition is included in national and subnational budgets. So now we're going to go over to Dr. Sevanti Ghosh, the Alive and Thrive Senior Nutrition Technical Advisor for India. Hi, Sevanti.
Hello, Sandy. Hello, everyone.
Great. So I have a question for you about advocacy, which we haven't really talked about that much so far. How did advocacy fit into the efforts to scale up maternal nutrition programming after the implementation research in India?
Thanks, Sandy. The advocacy efforts that we undertook actually started right from the inception of the maternal nutrition implementation design. As a member of the technical expert committee at the national level on maternal nutrition and maternal health set up by the health ministry, we took up this implementation research to show how feasible it is to integrate maternal nutrition through the nutrition and health system in the country, how to effectively integrate it during the ANC platform functioning. And that's how we shared our results, starting from the baseline, the process evaluation findings, and the program learnings on a regular basis at this forum, and contributed to the process of development of maternal nutrition protocols for integrating into the ANC guidelines, which were getting revised at that time. When the evaluation results came out, we did a dissemination at a national level as well as at the state level, using this forum of the technical expert committee under the leadership of the ministry to reinforce our advocacy efforts and sharpen and finalize the development of the maternal nutrition protocols. It also fed into the development of the national level training package, as well as the social and behavior change communication toolkit for maternal nutrition to be used by the frontline workers and providers. We work towards improving the government guidance in ANC guidelines for monitoring antenatal services, where there was a renewed focus on maternal nutrition services. We looked into the budgetary provisions, which was also part of our advocacy effort to ensure the government budgeting for health prioritize maternal nutrition service and counseling provision. We, along with partners in this advocacy effort, organized a series of technical webinars involving the institution, the academia, and the professional associations to disseminate the learnings and further take forward the agenda of maternal nutrition during ANC. Thanks.
Thanks, Savanti, and thanks for talking about academia and the professional associations. I know there's been a lot of attention to that in India. And one last question for you. In the theory of change presented by Tina at the beginning, she emphasized how strengthening capacity is a critical strategy for integrating maternal nutrition interventions into ANC. And I think we already have a lot of questions in this webinar about capacity and particularly capacity around counseling. So how is capacity built at the state level in India to make sure that those frontline service providers were ready to deliver high quality maternal nutrition interventions?
Thanks, Sandy. This is another very important question. As I mentioned earlier, we had worked out the national level training package, job aids and toolkits. We at the same time developed a pool of national level master trainers. And then we worked with the states which started integrating and prioritizing maternal nutrition protocols in their ANC platform to develop a state pool of master trainers. We involved even the state level institutes, the medical colleges, to be part of this training resource pool. And then the training was cascaded at the sub-state or the district level and sub-district level, that is the block level. And partnerships have been very important in this entire process of scaling up. And so development partners like us, UNICEF, Nutrition International, who are present in various states, they provided handholding support to the state government for quality assurance of the trainings that were happening at the district and sub-district level. We also are working simultaneously on developing e-learning modules with the National Institute of Nutrition and UNICEF on maternal nutrition for giving enhanced access to the training modules. And the training package I would like to share, we really had focused on the counseling skills, hands-on skills development, and along with capacity building, we emphasized on the importance of the post-training mentoring and supportive supervision so that the frontline workers were really supported to deliver the quality maternal nutrition services. So thanks, and over to you, Sandy, and to the next session on question and answer. Thanks.
Great. Thanks so much, Savanti. And thank you to the whole panel. I know that the webinar participants have other questions for the country panel and for our other presenters. So now I'm going to turn it right over to Dr. Sujata Bose, the Alive and Thrive Director for Monitoring, Learning and Evaluation, who will moderate the final Q&A session. Over to you, Sujata.
Hello, everybody. I'm Sujata Bose, and as per Sandy, I'm going to take some questions from you that you've posted in the chat. So if you've not posted your question yet, please feel free to do so right now. We will not be able to get to all of the questions, I suspect, in the time that we have, but we will try our best to answer as many of them as possible. So I'm going to go off camera to save some bandwidth, and I'm going to direct my first question to two people on our panel, well, to one person on our panel, to Dr. Abdulaziz Umar of the Ethiopia Country Program, Alive and Thrive Ethiopia, and also to our Alive and Thrive Myson Technical Advisor, Tina Sangvi. So there's a question about what we mean by counseling. Do we have a standard definition of counseling? In many countries, it can be interpersonal counseling, group counseling, or peer counseling. So what is Alive and Thrive's standard definition of counseling? And I don't know, perhaps we can start with Dr. Abdulaziz Ali Umar to get a country perspective, and then go to Dr. Tina Sangvi to get a global perspective. Thank you.
Thank you very much, Sujata. With regards to the counseling we are referring in this particular case, it is interpersonal one-to-one counseling. That's the counseling between the healthcare provider and the pregnant woman or lactating woman. So we have a contextualized job aid or counseling chart, which we are using at facilities, especially to give more guidance to the mother on specific areas of counseling. So the counseling we are using or we are referring in this case is a one-to-one counseling.
Great, thank you, Dr. Abdulaziz. And I don't know, Dr. Sanghvi, if you would like to elaborate and maybe elucidate in terms of what we do in other countries.
Yes, so we didn't limit the counseling to a particular specification, but the one-on-one counseling was always preferred, as Dr. Abdulaziz mentioned. However, the importance was multiple times talking about key behaviors, but also questions and answers with the mothers about what their concerns were, and dealing with not only knowledge gaps about what they should be doing, but also what are some of the barriers. Their belief in the benefits, their self-confidence in being able to address it, their access to resources. These were important elements in addition to knowledge transfer, and that was an important dimension of counseling that we felt in terms of bringing about behavior change that is often missed. We do have a checklist in one of our publications called Gaps in Implementation, and there's more specifics about counseling and other aspects of implementing that you might want to look into. And counseling tailored to the condition of the situation, the family situation of the mother, very important. And for example, in India, there were repeated efforts to observe and reinforce and share experiences across different antenatal care providers and also ICDS workers about what was working, what wasn't. Importance of supervision in ensuring the counseling was done. So there were many aspects of counseling that had to be addressed. And if the preferential mode of one-to-one counseling was not possible, we were perfectly open to having it in groups, large groups, small groups, depending on what the opportunities were in each of the countries. Thank you.
Great, thanks so much. I would like to address the next question again to two persons, to Dr. Sebanti Ghosh of Alive and Thrive India, and also to Dr. Feng Wen of IFPRI, who led the IFPRI research in India. So there's a question asking why the implementation research in India did not include facility-based maternal nutrition /ANC. So perhaps we'll go first to Dr. Sebanti Ghosh for a response to that question, and then we can hear from Dr. Feng Wen. Thank you.
Thanks, Sujata. The facility-based ANC component was not included based on the consultations that we had with the government in the country, both at the national and at the state level. The community-based platform was considered to be the prime platform for antenatal service provision. So we focused on the community-based platform, which included the community-based service delivery session of village health, nutrition, and sanitation day services. We had the India's Integrated Child Development Scheme, ICDS services, also operating at the community level using the Anganwadi center. And there was the home visits through both the Ashas and the Anganwadi workers. So this was considered to be the prime platform, and the consensus was that we assess the feasibility, how this platform can be really optimized for integrating and prioritizing the maternal nutrition services. Alive and Thrive separately has worked on the facility-based platform as well in partnership with the government, and there are protocols through the national government for improving the same as well. Thanks, Sujata.
Great, thank you. And then I'll just ask Dr. Fang Wen if she would like to add anything to what Dr. Sibanti has said.
Sorry. So I think Sibanti covers the main reason for why we didn't assess in the facility assessment already with the regard to the consultation with the government and also to adapt with the local context. So I have no further information to add. Yeah.
Okay, great, thank you. And the next question as well, I would like to address to two persons, to Dr. Maurice Gerald Zafi-Manyaka of Alive and Thrive Burkina Faso, and also to Dr. Sunny Kim, who led the IFPRI research for us in Ethiopia and Burkina Faso. So there are a number of questions in the chat about improving the quality of counseling. And I think you've spoken to how we've built frontline worker capacity, but there are also a number of related questions on how we've actually been measuring the quality of counseling. So I would like to ask Dr. Zafi-Manyaka first to speak from his programmatic perspective in Burkina about how we attempted to measure improvements in counseling as the intervention unrolled, and then go to Dr. Sunny Kim to get her perspective on how we measured this aspect in the evaluations. So first we go to Dr. Gerald.
Thank you so much, Sujata, for this question. This is very relevant. I want to share with you some of our experience here that is linked to this maternal nutrition. There was an opportunity in 2020, to review the indicators that will be collected nationwide here in Burkina Faso through the HMIS, Health Management Information Systems. So there we started, as I said earlier, we have already provided technical support to the government to develop policies, adopt directive and something like that. And for the HMIS, we worked with the government and we tested these indicators. We identified the indicators, especially for mycin in general, because when we look at we did an assessment of the HMIS at that time, so there was only one indicator, the early initiation of breastfeeding, who was collected, that was collected through the HMIS. So we identified some indicators, and that indicators include nutrition, maternal nutrition through antenatal care already. And we tested that. And during the implementation research, we just reinforced. And after the pilot, the government revised their list of indicators for the HMIS. And from January 2021, the HMIS here in Burkina Faso collected these indicators nationwide, including maternal nutrition area. And you know, we cannot have all long list of indicators, but just the most important. That is through the HMIS. And even through the national nutrition surveys that is conducted every year using the methodology, standard methodology, smart methodology. So we have integrated some indicators for maternal nutrition, including IFA, for instance. And with all of those indicators through the national HMIS and the annual nutrition survey, we can capture data, including process indicators and some impact indicators. And the government, with its partners, can analyze, use those data to make decisions to reorient policies and monitor the program at national level. Thank you. Over to you.
Thank you, Dr. Gerald. So now I'll pose the question to Dr. Sunny Kim, if you can explain a little bit how we measured quality of counseling in the evaluations.
Thanks, Sujata. So there's tremendous value in presenting the three country results and findings together, but one of the challenges is that we can't share everything and the context and the variations within the countries. Across all the 3 countries, we did collect data on counseling quality through observations, service observations. So in the case of Ethiopia and Burkina Faso, at the facility level, observing antenatal care, counseling or the visit being provided, and in India at the community level, observing the encounters with beneficiary pregnant women. What we observed in the quality of counseling is that especially with the tremendous support of the Alive and Thrive training and support, that frontline workers and service providers are incorporating more of the topics and messages and information, such as providing local food examples for messaging on dietary diversity, addressing more of the potential side effects of IFA consumption. And so we do see that in the messaging of the different, the specific messages that are being promoted across the different maternal nutrition interventions were being delivered and were increased in the Alive and Thrive areas. We also know that counseling certainly has other intangibles and other components like interpersonal communication skills and so forth, and the experience of care. They're not so, we didn't see as many of the changes, but we know that in terms of the delivery or addressing the topics of nutrition promoted by Alive and Thrive were being provided. So the quality of counseling was measured through observations. Over.
Great, thanks so much. And this is an area that's rife for further development. As we know, it's always very hard to measure quality of counseling, but hopefully that provided some good information on those aspects within our work. I'm going to address the next question to Dr. Feng Wen. It's about what standards were used for appropriate weight gain during pregnancy. And I'm addressing it to Dr. Wen because in India, we had a nested cohort in the implementation research that allowed us to track the same woman over time and to measure some of these biological outcomes. I don't think we were measuring weight gain in that way in the other 2 settings. So I would like to ask Dr. Wen if she can speak to that question.
Thank you, Sujata. Yes, so yes, you are right. In India, we have unique opportunity to follow the pregnant woman, and we follow them every month to measure the weight of the woman during pregnancy. And we are able to compare the weight gain of the woman during pregnancy between the ANT and the non-intervention control. The result we didn't show in the slide today, but it shows that the woman in ANT area who received the intervention, that means the counseling on dietary diversity and then additional food during pregnancy, they are able to gain about 0.5 kilogram of weight, more than the people in the control area. So I think the results are kind of promising and show the evidence of maternal nutrition have some impact on the weight gain during pregnancy. Yeah.
Okay, and I think the question is a bit more about, do we have standards for assessing whether a woman has gained weight sufficiently, and did that come into play in the design of the research? So I don't know if you agreed on a standard before following this nested cohort, or if you just decided it was sufficient to see whether there was a weight gain.
I'm quite not really understand the question. Sunny, do you get the idea? What does, yeah.
Right. So I think the question is asking about what growth chart or what growth standard was being used for the weight gain measurement. And I do know that in all the 3 countries, even though only in India did we follow up a cohort throughout pregnancy, we did not do this. We weren't able to do this in Burkina Faso or Ethiopia. That the program team adapted from the WHO weight gain charts, as well as some other learnings of studies, such as I think the Intergrowth 21 multi-country studies and lessons, and really adapted materials to come up with a standard the weight gain chart that was incorporated and inserted into the mother's health cards so that service providers can track and record the weight gain over time, and then also came up with the messaging that we're promoting 10 to 12 kilograms throughout pregnancy as kind of a common message overall. Again, at this and the other countries, we didn't it wasn't customized. For instance, there were no pre-pregnancy weight measurement and then tracking women's weight over time. But there was more common messages using and adapting lessons from previous other studies and literature. I think that's what's being asked. Shanta, over.
Thank you, Sunny. Yeah.
Great, thanks, Sunny, and thanks, Feng. So with that, I'm afraid that we're going to have to close out in the interest of safeguarding both our time and yours. And I would just like to close by drawing your attention to a few different aspects. If we can go to the resources slide. For those of you who are interested in learning more about what we have talked about today, we have already produced, IFPRI and Alive and Thrive, we've already produced several briefs and manuscripts that reflect the learnings from both the research and the interventions. So we invite you to peruse our website. Here you see we have an evidence map on research and learning, and on the slide it shows exactly where you would go to download some of the manuscripts related to this work. As well, IFPRI and Alive and Thrive will continue to work to produce additional manuscripts and briefs and knowledge products related to this work. So please keep your eyes and ears open for that moving forward. We will also be sending out an email with a recording of this session, along with the PowerPoint and some associated materials. And I know several of you have been asking whether you can have access to some of the country-specific tools. So we will get back to you about that as well. And then I just finally like to close out with a series of thank yous to people who have been indispensable in making this session happen. First off, a big thank you to Alison Tumilowicz from the Bill and Melinda Gates Foundation. Alison, you have been a stalwart champion, not just of Alive and Thrive, but of maternal nutrition more broadly. And it's been a pleasure to have your inputs and your support, not just today, but over the past couple of years as we've worked together. Next, I'd like to thank our colleagues from the International Food Policy Research Institution, Sunny Kim and Feng Wen, but also several other key IFPRI colleagues who did not speak today, but who have been integral to bringing this research to fruition. You guys always do stellar work, and you do a great job synthesizing and presenting the results. So thank you very much on both scores. Next, I'd like to thank all of my Alive and Thrive colleagues, both field-based and headquarters-based, who took time to prepare and present today. And a special shout out to the Alive and Thrive communications team, who've worked long hours to give this webinar shape and to make it a reality. And then I would like to thank our team of simultaneous interpreters who've been working silently, or not so silently for the Francophone audience, to translate everything we say into French as the session has unrolled. You guys have one of the hardest jobs imaginable, and although many of us can't see or hear you, we are aware of your presence and we are very grateful for your work. And then the last thank you goes to the group that really is indispensable for this session, which is our audience. We're really grateful that you chose to spend your time with us today. And we thank you not just for your presence, but also for your critical participation in posing interesting and important questions. So with that, I will close the session and wish you good day and good night. Thank you.